Greetings. Let us talk about pneumatic dilation of achalasia. These are my acknowledgements, and the learning objectives include: number one, we will learn about the role of a pneumatic dilator in the management of achalasia and how to set it up. First, let us learn and review about achalasia. The problem is in the muscle, and the lower esophageal sphincter is spastic and does not relax with a swallow, and the esophageal muscle does not contract properly or have the peristaltic activity. So these two disturbances produce difficulty in emptying the esophagus into the stomach, otherwise resulting in difficulty in swallowing, or known as dysphagia. When you do endoscopy in a patient with achalasia, the esophagus is usually filled with saliva, and once you clear that and reach the lower esophageal sphincter, you will notice that the sphincter is tight because of the tight lower esophageal sphincter. So this requires a pneumatic dilation to rupture the muscle so as to relieve the spasm of the lower esophageal sphincter. There are other ways to manage this problem, that is disrupting the muscle with the help of a surgeon who goes with either a thoracoscope or a laparoscope and cuts the esophageal muscle, or an advanced endoscopist tunnels into the esophageal submucosa, goes down to the lower esophageal sphincter, and then cuts the muscle and then comes out and closes the tunnel. That is known as peroral endoscopic myotomy or POEM. So today we will learn about pneumatic balloon dilation to disrupt the lower esophageal sphincter. So how do we set it up? Unlike the regular balloon dilations that we use, where the balloon is inflated with water, with a pneumatic balloon dilation, you basically pump in air to distend the balloon and rigidize that balloon. So that is something to keep in mind. Like any balloon dilation catheter, this catheter goes over a guide wire. So as you can see, this is a bigger device compared to the balloon dilation catheters that are used for dilating esophageal strictures that go through the endoscope channel. And under endoscopic vision, the endoscope dilates a stricture. With pneumatic balloon dilation, because the system is so big, it doesn't allow us to put it through the scope. You have to pass the guide wire into the stomach and take the scope out, and over the guide wire you pass the pneumatic balloon dilator under fluoroscopic control. So that is the difference between pneumatic balloon dilation and regular stricture balloon dilation. And you also need a lubricant to lubricate the catheter, and a little bit of gauze to put the lubricant on to lubricate the catheter. So before we go further, depending upon the type of the case, the endoscopist may decide to use one of the three different sizes of pneumatic balloon dilation catheters that are available. And these are based on the diameter of the catheter, the diameter of the balloon. So this is a 20 millimeter balloon. You could also have a 30 millimeter balloon or even 35 millimeter balloon. The larger balloons cause more disruption, more likely to cause perforation, so the endoscopist may try to start with a smaller balloon. Another difference between the regular balloons that we use for strictures, they stop at 20 millimeters. Start at 6 millimeters, goes to 20 millimeters. For pneumatic balloons, there are only three sizes, 20, 30, and 35 millimeters. So how do we go about doing the procedure? The endoscopist of the patient is put to sleep. He puts the scope down, goes into the stomach, and then deploys the wire. Typically a Savary wire is used. The Savary wire is placed in the antrum, and then as he pulls the scope out, the wire is inserted, and the wire, once it comes out of the mouth, you make sure that you have the 3 marks that are outside the mouth, that is at least 60 centimeters. You lubricate the balloon tip and then load the catheter onto the Savary wire and then slide it over the wire until it comes down to the area of interest. So once you pass the catheter, then you start the fluoroscopy and you watch the catheter going down, and then you position it across the GE junction, and once the endoscopist is happy that the waste is at the GE junction, he will ask you to inflate the balloon. So you inflate the balloon and watch under fluoroscopy as the balloon inflates. And there will be waste, and you try to make sure the waste disappears. And that, once that is achieved, depending upon what the endoscopist wants you to do, he may ask you to keep it for a certain amount of time, and then you measure that time and say, time is up. Some people use for 30 seconds, other people use for 1 minute. It all depends upon the endoscopist's choice. And after that's done, the balloon catheter and the wire are removed together. Since it involves disruption of the muscle, after the procedure is done, the patient is usually kept in the recovery room to make sure there's no acute pain, which indicates a perforation. And a contrast study of the esophagus is arranged to check for any perforation. And once there is no perforation, the patient can go home, and he will have instructions about what he needs to do regarding the diet for the first few days. So we've learned about pneumatic balloon dilation. This is used for achalasia to disrupt the muscle, and unlike the traditional stricture balloon dilation, where you use water with a gun to inflate, here you use just air. And unlike the stricture balloon dilation, where the balloon catheter goes through the endoscope, this one doesn't go through the endoscope, it just goes over the wire, and it needs to be done under fluoroscopy control. I hope this is useful. Thank you.